Good evening, everyone. Welcome to the Long COVID Clinic, What You Can Do, with me, Dr. Binita Kane, and
myself, Helen Oakleigh. I'm here representing charity Long COVID Support and our sister charities as well, which includes Long COVID Kids.
So we're really pleased to be back after a bit of a break. Hope everyone had a nice, restful and restorative Christmas and New Year. And we're going to kick off with a really brilliant guest. Don't forget that the session is live and interactive, so your comments, if you pop them in the chat, we will try and get through as many as we possibly can by the end. And with no further ado, I will just pop Helen backstage and introduce our guest. So bear with me one sec. So delighted to welcome Lael Yonker, who is a consultant pediatric respiratory physician, or what they would call a pulmonologist in the US, working at Massachusetts General Hospital, and is really at the cutting edge and forefront of research in pediatric long COVID. Welcome, Lael. So good to have you.
Thanks so much for inviting me. Happy to be here.
Yeah, and for joining us over your lunchtime over there. Exactly. So I think it'd be just really nice to start by telling us just a little bit about what you do and kind of how you got interested in COVID and long COVID.
Sure, absolutely. Thank you. So first, I want to say it's a good day for a fireside chat. It's quite cold and snowy here, so perfect weather. I'm a pediatric pulmonologist, as you mentioned. I work at Mass General in Boston, and I really have been focusing my career before COVID on how the body responds to infections in the lungs, the immune responses, and sort of what the infections are doing to the lungs and how the body's reacting. And part of my, one of the roles that I have outside of COVID is I'm the director for the Cystic Fibrosis Center. And so that's what really has sparked my interest in this area. When COVID hit, all efforts were paused, but it took about 2 days for us to realize that there's no way that children are spared from a respiratory virus or any virus. Children are very good at spreading these, respiratory viruses specifically. And so we quickly pivoted all of our cystic fibrosis work and sort of set up parallel protocols to be able to collect samples from people infected from COVID. And we learned a lot, or with SARS-CoV-2, and we learned a lot about how kids respond to the acute infection. We studied how kids were responding when this multi-system inflammatory syndrome, or PIMS as it's called in the UK, is MIS-C or PIMS, how that affects kids. And we've continued, and once we realized that long COVID was a clinical entity, we started trying to understand how long COVID was affecting kids. And so we've been setting up sample collections, symptom report surveys, and trying to tie together what we're learning, working with some really smart researchers to try to understand the mechanism of disease. And then we don't want to stop there. We think that's really great, but we want to make kids better. So we've also set up some clinical trials too.
Yeah, and I think you were kind of really quick off the mark with that sample collection and knowing that this was going to be an important thing. Now, what would you say to people who still to this day, 5 years later, kind of keep the narrative going that COVID and SARS-CoV-2 does not affect children and children are fine? What would you say to that?
Yeah, I think it is. I think it is increasingly, fortunately, appreciated, although not always. Which is why that kids can be affected with SARS-CoV-2. They're that's expected. It not as getting severity is not what it was the first few waves, thank goodness. Although certain individuals are at high risk, but then the long COVID component, I do think that is a struggle still. People don't realize that kids can have long COVID, and it is hard to sometimes tease apart, what might be happening with a child who, has mental health issues, for example, unrelated to COVID, versus those that do. I think that we'll need a clear-cut diagnostic so people can really understand what is caused from long COVID and what is not. But I was actually just talking with someone the other day, a reporter, about, why do we use long COVID in children? And I think it's really important to keep those terms attached because the children will just be sort of forgotten. So I think that long COVID kids, long COVID in children, I think those are important words to include when we're describing long COVID, even though I actually think, in contrast to acute infection, where there were differences in how kids responded to the acute infection versus the adults, I actually think that the way that kids respond in long COVID, what's happening in their body, is very similar to what is happening in adults. But I think we have to use the words, emphasize in children, so people know that kids also can be affected.
Thank you. And so that brings us on nicely into kind of how does the virus affect children? Should we talk about the acute infection and what happened in those really early days? And fortunately, we're not seeing this kind of severe disease that we saw in the early days, but you would have been at the kind of coalface of treating some of those children. Can you just give us a bit of an overview of that very severe illness? Because I think some of the people who are watching or will go on to watch this video will have children who perhaps were affected by that. And then I think we could probably talk about long COVID, in that there were some people who were very sick at the start and then had ongoing symptoms, but the majority of long COVID, in the sense of how we know it in adults, were from people who weren't very sick and had quite a mild infection. And that was what happened to my daughter. She had a mild infection and then just never got better and was really debilitated. And I think those are two slightly different things. And Dinello Buensenso describes that beautifully in one of his papers. But tell us about the acute severe infection first.
Yeah, when I think we've all felt this way, we get the upper respiratory congestion. There's a lot of sort of that antiviral inflammatory response in the upper airways, especially in children. In adults, there seems to be more of those with severe disease, more of a systemic, sort of through the whole body, this antiviral response, as opposed to kids. And I think that partly is because even in the early stages in severe disease, adults can have virus that leaks into the blood or viral particles that leak into the blood. And that's much less common in kids during acute infection. And so kids are better able to contain the virus to their nose, partly because kids have sort of cells that are within the nose that are primed to respond to viruses. And whereas you lose some of that sort of priming over time as you age. And so they contain the virus generally a little better in the upper airway. They clear it. It doesn't become systemic, except when it does. So in a few cases shortly after, infection, well, this is what we were seeing, in 2020 through 2022. And then it started to really cut down considerably, thankfully, but not disappear, is this MIS-C, or multisystem inflammatory syndrome in children. Actually, before I even talk about MIS-C, I want to talk about who is most risk for still getting hospitalized for acute COVID. And those are really the infants. And often it's not respiratory failure, but it's sort of, systemic and dehydration. But that is definitely the age group that has been the highest risk for hospitalization for a while. And those numbers haven't changed dramatically. Whereas, once vaccines came out for kids, we saw hospitalizations in teenagers and school-age kids drop dramatically. So there's still, infants haven't been vaccinated. So you still have to, be mindful that they're naive, they're susceptible for severe disease. Making sure the mom has adequate vaccination or, immunity helps prevent, she can pass that along to the infant, but that's sort of an at-risk and always has been an at-risk population. To switch now, sort of the outside of the acute infection, weeks to months after having an acute infection, we know that the virus is clear. The virus is cleared from the nose eventually. but it can set up reservoirs in the gut. And so what we see in Miss C is kids would come into the ER with high fevers, severe abdominal pain. Often they came in and they had an evaluation for appendicitis. And often when we were really looking for these patients, and they would come in, multiple per week. There were a lot of kids who were presenting with Miss C. And one of our screening, one of our sort of predictive values is whether or not they had an evaluation for appendicitis, and it came up negative. If it came up negative, and most did, we're like, I bet that's Miss C. If they had
that's so interesting, Lael. I'm going to interrupt you for a second, because 3 weeks of Jasmine's illness was, I tell you, the 8th of January 2021. 3 weeks after that acute infection, which wasn't severe, I was in work. I was on the respiratory ward, and she FaceTimed me, and she was unable to. My husband was downstairs and he was on a call, so she was unable to go downstairs. So she FaceTimed me and she was just doubled over in crippling abdominal pain. I literally dropped everything. I went home. Obviously, by that time, he had realized that there was something seriously wrong. I rushed her into A&E and I went, she's got appendicitis. And she had all the tests and they came back negative, and they were just like, we don't know what it is. And that's so interesting that you said that, because it's something that currently came up in the Long COVID Kids Facebook group. Especially in those early days, this recurrent abdominal pain. So what is Miss C? Is that like a vascular? Is it a blood vessel problem? Like, why does it happen?
So it's multi-system. So it affects many organs. But the vast majority of kids with Miss C, if not 100%, have GI symptoms. And, what we've found is also associated is they, often will have virus in their stool still, and they have increased markers of gut permeability, meaning...
So that's like leaky gut?
Leaky gut, exactly. And we find pieces of the virus have leaked into the blood. So we find very high percentage of these patients, not all. So I think that, like long COVID, I don't think it's a very tight definition, but I think that there's more of an umbrella for Miss C and for long COVID, and people can have some different prominent pathology or different sort of symptoms that they present with. But with Miss C, you see similar things that you see in long COVID. So stomach pain, a lot will have cardiovascular involvement, and that's the most severe. And honestly, most Miss C has sort of focused on those with cardiovascular involvement, because that's, a very, it's very specific and sort of unique concern. But you can also have rash, you can have neurologic involvement, you can have kidney involvement. So it's very multi-system. And so joint pain, swelling, lots of things. And we've learned a lot over time from Miss C, and I think this is important because it teaches us to keep an open mind for new diagnoses. I remember going to a conference early on, maybe like, a few months into COVID, and somebody was like, this is a classic chest CT for COVID. I'm like, classic chest CT, or like for Miss C. And I'm like, how do we know classic? This disease has been around for about, 3 months. So we're still learning. I think we still are. But what people have come to appreciate is that Miss C used to have a very strict criteria. And part of the definition was you had to be hospitalized. And that's not the case anymore. And so
I just want to pause on that point, because I think there'll be a lot of people feeling really validated right now that this is what I think my child's had, because they've had multi-system problems. I mean, I've had patients who, brought their, children, and they've had like thick, skin peeling off their hands and feet, like recurrently. They've had vascular looking lumps on their fingers. They've had headaches, they've had gut problems, all of this stuff. But because they weren't hospitalized, it wasn't taken seriously because it didn't fit that kind of mold. this diagnosis has therefore not been made by anybody, and it then goes just under the long COVID umbrella, and it ends up in the kind of fatigue management sort of pacing type clinics.
Yeah.
And so I think that's a hugely important statement, that actually you don't have to have been hospitalized, because it's a bit daft, isn't it, really, to make that a criteria, because if someone's really sick, they may stay at home, like lots of people did with acute COVID.
Right.
So, you know, thank you for sharing that, because I think that's a really key kind of message that will help parents who are watching.
And I think that that's important. So you know, it's interesting that you said you thought your daughter had some, you know, more mild MIS-C, and I wouldn't be surprised if many kids who have gone on to have long COVID had some form of MIS-C, because that hasn't been looked at. But I wouldn't be surprised, because again, the pathology is very similar, where in long COVID, we still have viral reservoirs. Many studies show that there's viral reservoirs in the gut. And so again, sort of that MIS-C is an earlier presentation, a little bit more severe, but if it continues and persists, then that sort of brings you to long COVID. And there have been studies looking at, we were part of one of these studies where they were looking at neuropsych changes after MIS-C. And
these are the brain inflammation changes, right? The neuro brain psychiatric kind of those kind of symptoms where people develop tics and OCD and real acute behavioral personality changes, all of these kind of things. Continue.
Exactly. Though, and so they were seeing that after MIS-C, there were differences compared to people who did not have MIS-C, and those persisted. And some of those changes, they're not, you know, they're executive functioning, their memory, things that we're seeing in long COVID. So again, I think that there is this, I think that would be a really interesting question of how many people did have sort of, you know, if they were to think back, had an episode like your daughter where, you know, there was some change, some sort of not feeling well a week or 2 weeks after, a month or so after having had COVID.
Okay, so we've got this kind of like really severe, end up in hospital, probably get diagnosed with MIS-C and maybe get some treatment. Then we've got this other group, didn't end up in hospital, may have been really poorly with MIS-C and undiagnosed. And then we've got this other whole kind of basket of different types of long COVID, a lot of children presenting with POTS, mast cell activation syndromes, PANS, you know, that's pediatric acute neuropsychiatric syndrome, which is this brain inflammation. And there's all these current things, like these kind of buckets of symptoms and problems, which we throw under the umbrella banner of long COVID. And I know that you have been working quite hard to try and understand some of the different groups and types of long COVID. So can you tell us a little bit about your research? And firstly, can I just say on behalf of everybody in the world who's affected by this, that, you know, that for doing this research, because you are like a unicorn, you really are. And so is Danilo, and so is David Petrino, you know, and these people who are just really putting their efforts, you know, just genuinely thank you, because there's not too many of you doing this, and we're very grateful. Can you tell us about your research?
Yeah, sure. Thank you so much. And I do love the collaboration and the shared passion amongst everybody who is doing long COVID research and trying to advance clinical care. So it's definitely a group effort. We need more people to be working on this. So my research is looking primarily at I have a couple different areas, but you know, what is causing long COVID? I do, again, I focus on long COVID in children, and I try where earlier in the pandemic, I was trying to understand the differences between the adults and the kids. Now I feel that there's a lot of evidence to suggest that there's similarities in what's driving disease and long COVID with adults and kids. And I think that just, again, when you read most research on long COVID, it's adults, 18 and older. And so it's really important to emphasize and to include pediatric samples and like blood products or whatever from children who have long COVID, and include children in clinical trials as well. And so my effort and is sort of advocacy through research. I try to show that, I'm trying to see if there are any differences or what we can learn from kids who have long COVID in order to help everybody. And so we're looking at a lot of the inflammatory response. We know that in people with long COVID, there's inflammation, or the body's revved up for some reason, and we're trying to understand why. I look at neutrophils a lot, and neutrophils are sort of the first responders to an infection, but for some reason,
they're part of the immune system, aren't they? And they're really important in that initial response.
So I think of them as like, the first responders. So they're the first ones to be activated, but and then they usually calm down and the rest of the immune system picks up. But for some reason in long COVID and in MIS-C, they're just constantly activated and trying to figure out, why they're good in a short burst, but they can be quite damaging long-term or in the wrong places. So trying to understand why these neutrophils are activated. And then also we're looking at the role of the gut in long COVID. And so again, looking at viral reservoirs, looking at the, collecting stool samples, trying to understand what the gut looks like. We see that there's increased markers of leaky gut, and we do see that spike protein is leaking into the blood. Not in all patients, but in a subgroup of patients, there is spike leaking into the blood. And again, I think that speaks to the umbrella of many different, types of things that have gone wrong to cause long COVID, but also, or I should say, maybe there's a sequence of events that occurs. I don't think we know which one is driving COVID.
So one of the theories that you are very much working on and proving to some extent is that in the gut you get these kind of what we call reservoirs. In other words, like viral bits of virus persist in the gut, and the gut, of course, has an absolute highway to the rest of the body, and there's a highway to the brain, and there's through the gut we absorb all of our nutrients that go into the bloodstream, and if you've got spike going into the bloodstream from there, that's why it can have access to the rest of the body through this leaky gut. But you're also looking at the impact on the blood vessels as well. And I know that you've published something looking at clotting and abnormal clotting markers in children. Can you tell us a little bit about that?
Yeah, so some has been published, some is still work in progress. But we have shown that, microclots have been described in people with long COVID, and we do see those increased in children with long COVID as well. And again, you really shouldn't have much, if any, long COVID, microclots in circulation. And I think part of that, again, we're trying to understand why that happens, but there is definitely inflammation in the blood. There's vascular activation, and these microclots can be detected in circulation, and those can be. Others have shown that those can be triggered by spike, and so again these might all be connected, and
you've also found that there was markers of the platelets being activated as well. So platelets are kind of, their job really is to parade the blood vessel walls and detect damage to blood vessels, and then they get activated and they can sort of trigger abnormalities in clotting as well. And you found evidence, like we've seen now proven in thousands of adults since the work that's been done in various research groups, but you found that replicated in that group of children that you're looking at.
Exactly. Yeah. So I think the couple of things that are going wrong is there's a reservoir in the gut. There's leak of spike into the blood that activates the neutrophils and the immune system. It also irritates the vessels and can trigger microclots, and all of these sort of build. And then there's also, the spike can activate the immune cells to create autoantibodies, and that's sort of a whole nother component of what can go wrong in long COVID.
So that narrative, and I think I've sort of said for a while, especially since we had our very first conversation, which was probably easily a year ago. And I thought, I remember us chatting, and I was saying there's going to be an approach to treating long COVID where we need to fix the gut, we need to treat the blood clotting abnormalities, we need to look at the nervous system, which we haven't really talked about here, but that's the thing that kind of goes wrong, the autonomic nervous system with POTS. And there's going to need to be a sort of 3 or 4 pronged approach to really understand how we get people better, alongside the resting, the pacing, the very careful energy management. So there's not going to be like a magic bullet. And I think what we desperately need the research to tell us, and I think this is the great work you're doing, is like, how do we identify those people who are going to benefit? And I really want to move on to like treatment, because in another sort of unicorn-esque achievement, you have actually done a clinical trial of a new agent in children with long COVID. Can you tell us a little bit about that?
Yeah, so we're studying something called lorazepam, which is a zonulin inhibitor. And zonulin is a regulator of those tight junctions in the gut. So zonulin, when it's released, sort of zonulin, when it's released, will cause a leaky gut. And so when it binds to its receptor. So this blocks the effect of zonulin when it's released, and tries to
kind of blocks the leaky gut and kind of makes it a bit more, so stopping that spike protein leak thing. Yeah.
Exactly. And so this came off of our MIS-C work, actually. So what we had done with MIS-C is we saw, again, like I said, we saw that there was virus in the gut. We saw increased markers of this leaky gut, and we saw spike in the blood. And so we had a very sick patient who was really just had very severe MIS-C and was not responding, or would sort of temporarily respond to their standard treatments, which were steroids or IVIG, but then his symptoms would rebound, and we saw he had tons of spike in his blood. And so we, received all the approvals, and we started him on this lorazepam, and we saw his spike drop precipitously. And it hadn't, we'd been sort of collecting and testing along the way, and we hadn't seen his spike budge. And they started this, and the spike dropped. His fever curve improved. He got much better. And so, that sort of showed us his inflammatory markers all improved. So with that, we then said, okay, we've got to start treating other patients and seeing if this is helping their MIS-C as well. And we did. And then we did similarly see a good response, better compared to controls. So we said, okay, we need to do this in a standardized way. We have to test this. And so we have to compare it with placebo. So then we had a clinical trial where we looked at the effect of lorazepam compared to placebo. And again, as we'd seen, there's a benefit in spike clearance and symptoms and inflammatory markers. And that is a paper that is, we wrote up and is submitted and is under review currently. So hopefully that'll officially be out soon.
So Lael, that's going to be such really incredible news to lots of people listening who are probably not aware even that clinical trials been done, that there's this something that's helping children. Yeah. But this was done in a group of hospitalized patients.
So that was hospitalized. Now we've switched it based on what we've learned. Those were the hospitalized patients with MIS-C. Earlier, when we were seeing a lot more MIS-C cases, now we're doing a study in long COVID with lorazepam, knowing that the mechanism of what's driving the disease is at least, is similar, at least from the gut perspective. And so, you mentioned that there's probably not going to be a silver bullet, and I agree, but a lot of the other clinical trials are looking at the inflammation. And the way I think about it is, it starts with a viral reservoir, there's leaky gut, and then there's immune activation. And so if you target the immune activation, maybe the gut is recovering on its own, but it would be really great if you could prevent the leak of the gut. People have also targeted the viral reservoirs, but so far those studies have, looking at prolonged courses of Paxlovid, what's been tried so far hasn't been successful, but that would also be a really good approach to start sort of more upstream and then try to improve things downstream.
Yeah, and it's really interesting, that story you said about the inflammation drugs that you were using for that particular case, the steroids, the IV immunoglobulins. They were helping to a degree, but then there'd be a rebound. So again, if you don't treat the root cause of the problem, these anti-inflammatory approaches may not work, or you may get stuck on these drugs long term.
Right.
It's interesting because there obviously is a cohort of adults who do get better with treating the blood clotting abnormalities, but almost like you let their body catch up with, the balance of clotting versus anti-clotting by giving them a hand with blood thinning drugs. And it almost gives them enough recovery to then heal the rest of the body. So I think there is probably a group that could do with just the downstream stuff. But there is definitely people where they've tried that, it doesn't work, and you're like, why? Like, that wasn't the thing driving their symptoms. And we are very much shooting in the dark as clinicians. We are kind of guessing what's going on, trying different treatments and hoping for the best, because there isn't like the clear diagnostic tests. There isn't kind of what we call biomarkers, which are the kind of markers of things we can measure to see if they're getting better. Even now, like 5 years on, we're still kind of shooting in the dark, which is a bit sad. And that's in adults. Like, forget children, they've got even less. Just on that front, do you think there could be a diagnostic test in all of this? Like, do you think measuring spike in the blood, measuring zonulin levels, measuring microclot levels, do you think all of these could be potential ways we could help make a diagnosis outside of just symptoms, which you've already said is really problematic?
It's a great question. So microclots and zonulin are not specific to long COVID. So lots of other things can cause these, other illnesses can cause both of those complications. Spike is specific to SARS-CoV-2, but there's not been a real study to show that it's causative versus correlative. And so
can you explain what that means, just to people who don't might understand that concept?
Is it causing the disease, or does it happen to be detected in people who have the disease, and it's just sort of a bystander that we're picking up? And my sort of feel, to me, it makes sense that this is abnormal. There's lots of studies to show that it causes disease in a tissue culture dish, but nobody, we don't have direct evidence. So there is criticism about that potential. I think it's the closest thing we have to a diagnostic currently. But it's not everybody. Part of my screening for my clinical trial is people have to have spike in the blood, and more people don't have spike in the blood who have all of the symptoms of long COVID than do. And there was a large study that came out a few months ago, now looking at adults with long COVID. And I believe it was between 20 to 40% of adults with long COVID have spike. And that, is variable. Sometimes you have it, sometimes you don't. And so it's not a perfect diagnostic. And so I think that we should learn from all of the work that's being done. And maybe there's, maybe it's not one diagnostic, maybe there's a panel of diagnostics. And we know if you meet the symptoms, so you have that clinical criteria, and again, meet the symptoms should be broadly inclusive, because long COVID covers a lot of symptoms and we don't want to pigeonhole ourselves. But if you have symptoms suggestive of long COVID, and then you have, one of the various biomarkers, I think that would be helpful, and also would give some advice, gives insight as to what would be the most helpful way to treat your symptoms. So if you have a lot of microclots, then targeting those microclots is going to be a better treatment strategy for you than for somebody who has, more of an autoimmune profile without as strong of a microclot profile.
Yeah.
So.
And I think that just comes down to I'm a chest physician by day, if you like. And something like, for example, severe asthma. Years ago, all we had was steroids, which is a bit of a like sledgehammer kind of, here, take some steroids, like just like the sledgehammer approach of anti-inflammation. But now we have all these really specific, like we can really work out what's going on in this individual patient. Do they have high levels of this? And then we will target them with that drug. And then is this group, we might use this drug. And they're all very, very specific in what we call kind of personalized medicine. And I feel like we're so far off that in long COVID because the investment in the research hasn't been there. And that's just in adults. Like in children, it's even more of a kind of barren sort of desert land, if you like, in terms of research. There's going to be, I think, a lot of people going, lorazepam, like, how do I get my hands on that? Like Googling the black market right now as we speak. Like, can we just kind of, like, it's still experimental. It's promising. It's not going to maybe be the be all and end all. How do you administer that drug?
Yeah, so it's not FDA approved. It's not clinically available at this point.
So you can't get your hands on it. So stop Googling. Yeah. Okay.
And honestly, I would be concerned if you could, because it's not through a pharmacy that is tightly regulated by the by the regulators. So, but we're testing it. We don't know if it's going to help. And also, we're looking at a specific population that seems to be most likely to respond. So we're doing testing to look for biomarkers that would suggest there'd be more. Again, long COVID, there's a bunch of different types of, we sort of talked about this, a lot of symptoms and predominant pathology. So I think that, again, we need to test to see if it's effective. And it's not available. So I wouldn't recommend anybody try anything that outside of a really, reputable and safe source. You don't want to put that in your body. So.
No, I just wanted to make that clear because people will be like, oh, can we get hold of this in the UK and what have you? And we will we'll bring Helen back on in just a moment, but there's a few questions that are about sort of measuring spike and how do you measure it in the blood? How do you measure it in the stool? So how do you guys do that?
Yeah, so there are a few different ways of testing for spike. We work closely with some collaborators, David Walt and his lab at Brigham, Mass General and Brigham are sort of sister hospitals. And he has an assay that he's designed to test for spike, and it seems to be the best one that's out on the market. His isn't actually on the market yet. His is a research test. So we're fortunate to be able to collaborate with him, and that's how we test for spike. We do test samples in the US. We don't have good confidence that the stability of the spike in the blood will last from transport internationally, because usually they hold the blood samples for several days, and then the stability of any spike wouldn't be detected. So, but if in the US, we do have protocols in place to be able to have blood shipped, and we have it overnight shipped, and we check the next day.
And in the stool samples, is that something you're routinely checking as well?
We are not routinely checking the stool sample. So what we did in Miss C was we looked for whole virus. We did a, like a PCR that you would do on like a nose swab, but the antigen, the assays don't detect antigen in the stool. It's just, there's too many other antigens around. And then, so we're banking stool for now and going to try to look at it once, later and try to see. That would be great if we could develop some sort of stool-based diagnostic.
Yeah. Okay. And then just my final question, because we don't really have this problem in the UK because most kids are not vaccinated in this country, but where does kind of vaccination fit in with like measuring? Can you tell the difference between spike from infection, spike from vaccine?
Okay, so that's a really good question. And this is something that we've looked into because so spike, when you're vaccinated, it is most people in a cohort early on in sort of that first round of vaccination would get a small, very transient rise in spike protein in their blood, and they would clear it after the first vaccine. they wouldn't have it after the second vaccine. And I would sort of think that as you had built your immunity over time, either through prior infection or prior vaccinations, you wouldn't have that bump again. That would be my guess. In some people who did develop severe myocarditis from the vaccine, you would see spike in the blood, and for some reason it wasn't being cleared, and that seemed to correlate again with what those who went on to develop some complications. Yeah. But that is rare, and very specific people presenting with like complications from the vaccine. Yeah. Most people, the spike itself, the actual, piece of the virus or the piece of that vaccine that's training your body is cleared. And so the vaccine should not be causing any long-term antigen.
Yeah. And again, I do think that we just need that research to understand who was susceptible to the vaccine injury, and let's do something different for those patients. We need to screen people to understand, it's a rare side effect, but when you give billions of vaccines, that becomes less rare. So that is something that I think, again, the toxic sort of conversation around vaccines and the politicization and all of that has made that really difficult to have that conversation and drive the research forward and the science forward. But I think it's just important to acknowledge that, vaccine injury is there. And much as vaccines, I'm very pro-vaccine. I will treat people with vaccine injury as well. So I think that's a kind of useful context to put it in. And just before the very, very final thing before I bring Helen back on, can we just talk about prevalence of long COVID in children? Because what we've talked about might sound scary to lots of parents, but this isn't the majority of children. So I just want to reassure people as well that most children don't get long COVID. So what do we know about prevalence?
So, I think of, so there's two sort of different ways of thinking about it. How many people will develop some symptoms after having had COVID, some new onset symptoms? That prevalence, there have been studies looking at symptom report, and it can vary quite a bit depending on what symptom you're looking at. But roughly, just sort of guessing, around 10% of kids will have some sort of lingering symptom. And that's a lot when you think about all of the kids. But I think that there's long COVID where your life is impacted. Ideally, we come up with a treatment, a detection and a treatment or prevention, so nobody has any symptoms. But I think long COVID is really when your life is impacted, when they're refusing to go to school, when your life has shifted because of having had this infection. And those kids are fewer. And again, variable studies based on what people are looking at, but those numbers are definitely lower. And it's really about, we don't want anybody to have lasting effects from a virus, but mostly we want people to be able to go to school, socialize, participate in sports, and grow up to be productive, happy adults. And so I think those are the prevalence overall of long COVID is probably decreasing slightly. And I don't know exactly why, but it's there. And
I think the big UK study sort of, I think most people agree on kind of 7%. And then the big UK study showed that some kids, at 2 years, 70% of those kids, their symptoms had recovered, but that does still leave that 30%. So it's not, you could sell it as a good news story or a bad news story. You go, well, actually 2 years is a really long time to be sick. And then 30% don't even recover after that. Or you can go, hey, yay, 70% recover after 2 years. So I'm gonna just bring Helen back onto stage, but thank you for that, Lael. And I'm sure Helen, welcome back, has been keeping an eye on the chat and may have some questions of her own as well. So I'll hand over to you, Helen.
Yeah, great. Thank you so much. Really sad that it's needed, but necessary information. So thank you. So we named our channel the Long COVID Clinic What You Can Do, because it's all about what you can do in practical terms. So For parents and guardians out there who want advice in a real kind of succinct way, like what are the big tips that you would say, well, it can't cause any harm, but it's a good idea if you were to look at this, like whether that's diet or sleep hygiene or whatever you think might be a really good practical thing to.
Sure. I would say, and I say this based off of some research that we just had, just surveying different providers. I would say if you're concerned that your child has long COVID, you should mention it to your pediatrician, because they're not always going to be thinking about long COVID. And if you're sort of like, well, these are the symptoms, and I'm sort of thinking about, if you're in your back of your mind thinking about the symptoms and you just talk about the symptoms, they might not all tie together for the provider. So I would say if you are concerned about it, that is the first thing, is bring it up and see, what your pediatrician might be able to offer. That's the lowest, that's really easy, just to sort of self-advocate for your child. We all need to do we have to put a lot of work into advocating for children because they aren't as good about doing it for themselves. And then, I think other important low-hanging fruit, making sure you're getting enough water, staying hydrated. None of us get enough water. I confidently say that about myself, but if you're having symptoms of POTS, that's really important. And that is, that you're getting enough water, that you balance it with some salty food as well. And then just, listen to your body, listen to your kids. And sometimes pushing is not necessarily the right thing. I think there's, a balance in trying to advocate and do what you can for your child. But sometimes, and I think most parents sort of learn that your child is only going to do what your child is going to do, and they'll lead the way. But I think listening to them and advocating for them, and then simple hydration is really important.
Well, we have this kind of policy in the UK, Lael, where they're very, 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 they're very heavy on attendance at schools. Yeah. So we have like attendance targets, and they will literally send your kids home with a thing saying they've missed, like, they could have missed 2 weeks of school because of like genuine respiratory viruses over Christmas or whatever. And you will get this letter going, attendance has dropped to 87%, now at risk of serious harm to education and things like that. It's really heavy-handed. And then if children are out of school, even for legitimate reasons, there's always that push to get them back in. And it's really hard for parents, because a lot of these parents, their children haven't been diagnosed because we don't have effective services that can do that properly. And they don't have a diagnosis, so it's hard to get a medical plan. And then they've got all this hassle from school. And it's no man's land sometimes for months and months on end. So the advocacy and making sure that you don't push them despite all that pressure from school can be quite hard sometimes. But it's a really tricky space to navigate. And even me as a respiratory consultant, and the school have been brilliant, like absolutely were brilliant. But I think part of that was because I'm a respiratory consultant, and it's very variable what people's experiences are. But please don't push. Do not push the kids. Exertion makes them worse. They need rest. Let them sleep. Let them rest. Let them recover. Conserve the energy. It's the best way of preventing disease from getting worse. That's like, I can't emphasize that more. We did exactly the opposite at the start of Jasmine's illness, and she paid dearly for it.
Yeah, absolutely. And I think a lot of adults did as well. And of course, there's a lot of crossover. A lot of children started off with this and are now adults, those who haven't got better. So, sadly, there's a lot of lessons to be learned. It's not clear cut. At this age, it's this, and at this age, it's that. It's, it's this huge amounts of crossover and learnings that can help all groups. So, good stuff. In regards to coming back to the tips then, what are your thoughts on types of food? For example, more of a keto-based diet, more protein and very small meals at regular intervals, or avoiding certain types of food, having fermented foods? Are there certain types of things you're like, well, yeah, that's a good idea, can't do any harm if they'll eat it? Obviously, taste is a big difficulty when feeding children as well.
That's very true. I don't have I haven't read anything that really suggests one diet over another. People wonder about the leaky gut. Leaky gut can be seen in celiac, for example, but this is unrelated to celiac. And people with celiac aren't at increased risk of having long COVID. They're sort of two separate entities. And I think there's the complexities more of like that, what antigen is sort of what is leaking across the gut rather than the leaky gut itself. So I think that I don't have specific guidance for diet. Binita, do you?
I think it's really difficult because some children have mast cell activation and different foods will trigger their histamine responses and gut problems and rashes. And then you've got another group of kids who've got POTS, and so they feel really nauseous and they have to have really small and frequent meals. And then you've got some kids who have no taste or smell. So actually they're put off any sort of foods. I get some kids who've got, they almost develop a food phobia because they feel so sick when they eat. And then that can be really tricky. And then a lot of the time you're dealing with teenagers who are going through those hormonal behavioral changes anyway, and food becomes an issue. So I think trying to give advice here's a blanket sort of how you treat this in terms of diet is really difficult. It has to be individualized, and there's no research to back up anything. I think it's just dependent on that individual kid's circumstances.
Yeah, trial and error then. So we had a question, is there any more plans for UK research on long COVID in children? And I guess to open that up more, where's the best place to be looking for research when it comes up? I know, for example, Long COVID Support, the charity that I'm part of, we have a separate page dedicated to that, but that's one place. But of course, there must be lots of other places where people can look. Any tips on that? I know it's not easy.
So I can probably come in. So the Long COVID Kids page, so just shout out. I mean, I think everyone watching this will have already discovered the Long COVID Kids charity, and because it's been an absolute beacon of light for filling a gap, that massive gap that exists in terms of resources support. So Long COVID Kids charity has a full research page. Everything new is just dumped in there on a very regular basis. The team do an amazing job at doing that and maintaining the web page. There's school resources, school support, everything you need in the UK is on there. I'm not sure about the wider international audience, but I know there's a lot of international people who are on that group as well. There's the Facebook page, which is very active. So that's kind of a really good resource. There's also the Turn2 app, and Jess from Turn2 is going to be on one of my guests in April. So that's a new app which is trying to mine the absolute minefield of information about long COVID and then deposit into a sensible place with high level sort of summaries of the research. And it's a really good resource, and we'll hear more about that when I speak to Jess. Lael, any other big resources you can think of?
So within the US, there's a, sort of a centralized Recover study for adults and then Recover kids as well, or Recover in children. And so those are good national research resources. And then I look at clinicaltrials.gov to see what sort of clinical trials are out there. I will say that our clinical trial that we're looking at is currently the only one that includes children. So something that I would like to change. And Binita and I have sort of voiced, along with other long COVID clinicians, long COVID pediatric clinicians and researchers, voiced our strong opinion that we really need to advance clinical trials, but that's always something as well. Those are more US focused though.
Yeah, I mean, just back to the UK question, it is quite sparse at the moment. So there is a big study going on in London with Natalie McDermott and Danny Altman, where they're looking at MR scans of the brain and looking at sort of describing various other things in children with long COVID. But we don't have treatment trials, and and it's just very difficult and very slow. So just for anyone who contributed to the children's microclot study that we collected the samples over the 2023, I think it was now, we are, that study just is still not finished. Samples still have not been fully analyzed, and it's because of the mountains of red tape that we've had to run through. But I'm hoping in the next few months that it's going to change. And I promise we will tell you what that study shows. I know people went to a lot of effort to come, but it's very, very slow without that UK concerted effort to fund these studies and to get researchers involved. It's really like hard work. It's wading through treacle, sadly.
Yeah. Absolutely. So got another question from Rebecca L. Unfortunately, many parents, and I've chosen this one because it encompasses so many of the questions are very similar to this. Many parents have experienced gaslighting and referrals to the somatic clinic when speaking to the children's doctor about symptoms. Any advice, let's keep it, any advice about how to advocate for their children? And I guess in general as well, to encompass some of the other questions, like what are the best ways to present symptoms so that you can best show this is what an average day is like? And is that useful, or is it too much?
Yeah, no, that's a great question. And I'm so sorry that you have to experience that. I would say if somebody's really gaslighting and minimizing, or, sort of saying, well, we need to sort of train, do something like it's a, mind over body sort of situation, then I would, seek another opinion from somebody who is more open to the idea of long COVID in children, because that's just challenging. I don't think you're going to get very far if somebody doesn't think if they're not believing you. And so you need to just find a provider who listens to the symptoms. And it doesn't necessarily have to be a long COVID clinic. I think that there is, long COVID's been around enough, long enough that maybe, there could be local providers too. It just might not be the right individual. And so when we did actually survey a bunch of providers, there was a ton of variability on what people would do. And there was no regional differences or sort of within a group, people would do one thing or another. So I think it's finding somebody who's going to listen to your symptoms and try to tease out what are the symptoms. And so, rather than just saying you've got to, learn to deal with it and then get back on track, you've got to really look for what are those objective signs. And sometimes they're subtle, and you need somebody who's got an open mind and is a good diagnostician and work with them and express. I just think keep pushing. You've got to advocate for your child. Nobody else is going to do it.
It's really tricky, Lael, because I think in the UK, a lot of the existing services for ME were very therapy based. Some are run by psychiatric services, so they're very psychologized. And long COVID has sadly kind of been lumped in the same kind of bracket. And even kind of the pediatrician, a pediatric colleague who really supported me to get the ethics for the children's microclot study. When I first talked to her, I think she's a really good person, like really good pediatrician, said, well, it's not really a thing, is it? We don't really see it. And I thought, what do you mean you don't see it? Whereas I'm on this Facebook group with like thousands of people. But I think for any individual pediatrician in an individual clinic, they might not see it because it's not getting referred to them, and certainly now no one's testing, people aren't putting two and two together. So pediatricians aren't really seeing it, and their experience of this kind of chronic fatigue stuff is kind of what they've been taught about ME. Then you can sort of see how it happens. And there is another whole live stream that I did about medical gaslighting. So if anyone wants to really delve into why it happens, have a look at that session. It's on the live page of the YouTube channel. But it is really difficult. And then when parents do advocate or they go and see a private physician, sometimes that leads to safeguarding concerns. So then they've got social services involved. Say they're not going to school, they've sought another opinion. Parents aren't engaging with the psychological support. Children's refusing to go to school. You start seeing this kind of language where the parents and the children are blamed. and then suddenly they've got a safeguarding referral slapped. I mean, it's commoner than you think, and it's really scary for families. So there's a kind of, that's just a whole other world of pain
so
on top of having a sick kid.
Yeah, it's complicated.
And I would say, you know, it is really difficult when it feels like there isn't much help or support, but what we can do as a community, and that's what we're doing as part of the various charities, and that is we try and bring awareness, and with awareness you can get research, you can get funding, you can get more help. So I'll do a bit of a general plea actually at this point, if that's okay. It's Long COVID Awareness Day will be coming up in a couple of months on the 15th of March in the UK. I'm pretty sure that's globally. And so what I would say is, you know, make your voice heard, make people aware that it is a thing. It's difficult when you've got a condition, which means you're in bed all the time and you're not well enough to advocate. So friends and family is exactly who is needed to advocate and say, actually, yes, I've got a child, or I know someone, I've got a neighbour, whoever it is, you know, and get involved with things that are happening. If you want an arts and crafts project, for example, which might be useful for kids as well as adults, obviously. Long COVID Support putting together a banner which is going to be presented on the 15th of March in London. So if you wanted to get involved in that, you can put your artwork together, send it in the post. I think the deadline is the 1st of February, I believe, and get involved and be part of a change, because a lot of conditions over the years have been new at some point and have been learnt about at some point, and we need as many voices as possible. So thank you to those of you who are doing that, and please do join in if you're feeling that you might have capacity to. It's all useful.
Thanks, Helen. That's such an important message to kind of conclude. And I've just got two little things I want to just mention before we finish. So I just want to say, I've talked a lot about Jasmine. So she was 10 when she got poorly. She's 14 now. She's living a completely normal life at school full time at 100% attendance last term, which is, you know, just stuff of dreams really. A couple of years ago, she's currently at a sort of a martial arts class this evening after school. You know, she's just better. She still does have a limit, but you know, she lives a completely normal life, and recovery is possible with the right support and help. It's really important to keep that hope. And secondly, there is a big government task and finish group at the moment, which has got representation from all the key charities, which are looking to reset the ME and long COVID services in the UK, and that's going to be published in March. So all the noise that you guys are making and the charities are making and the advocacy, it is creating change. So I just echo what Helen is saying, like, please keep it up. And so that just leaves me to say a massive, massive thank you to Lael, not only for all your work, but giving up your time to come and talk to us about it. And thank you so much. We'll be back on the 5th of February. I think I've got a really amazing GP turned breathwork practitioner. We're going to talk the science of breathing and why that's so important for recovery. So thank you very much, everyone, and I'll see you next time. Take care.
Thank you.